We have about 10 minutes left, so I want to get through a couple of topics quickly. One is we still struggle now with which patients preoperatively, especially postoperatively, in a world where we have treatment choices for postoperative therapy, which patients really need it and which patients are cured already from the surgery. We don't want to overtreat those people. And, certainly some patients with stage 1 disease and a subset of patients with higher stage disease are as cured as they can ever be. And we don't want to extend years of therapy and potential side effects and cost. We have new technology, circulating tumor DNA, that sometimes detects what we call minimal residual disease. You can find some small amount of tumor DNA in the bloodstream. It is not a standard test right now. It's just looking provocative. So I would ask you all where you see this now. I mean, are you using it? It's starting to be kind of marketed ahead of a lot of data. Where do you see it now? Where do you see it in the future? Is this likely to be a tool that in 3, 5 or so years is as widespread as PET scans in our management? Riyaz, can I start with you here?
Yeah, it's very timely because there's been certainly a very interesting publication recently that was that I've seen on Twitter on this very issue. Unfortunately, Twitter's where I get a lot of my up-to-date medical information from. Look, I think that where are we going to be in the future? I've no doubt that ctDNA technology, so liquid biopsies, are going to provide a lot of information in this space. They hopefully will be able to predict for us the patients who are going to relapse. And then we need prospective trials, because we do need to check this prospectively to check whether early intervention with chemotherapy, immunotherapy, whatever it is actually going to change the biology of the disease in those patients. We need to see if adjuvant chemotherapy works in people who are molecularly negative. I mean, I've no doubt it'll have a role, but there's a lot of questions that need answering in prospective, well-designed studies.
Narjust, your thoughts here?
So I'm a little bit more on the conservative side because we don't have good data about it, and I'm afraid that patients are going to be called failure. They're going to say that they failed treatment or they had disease progression and they're going to be starting on therapy too soon. We don't have tumor markers in lung cancer like other diseases like pancreatic cancer, breast, or colorectal cancer. And we have learned from those diseases that sometimes back in the day, we used to follow these tumor markers and patients were going to be starting chemo based on a number. So I'm very conservative about circulating tumor DNA in early stage as calling a disease progression when there's nothing in the scans. I think, yes, there is going to be a role for ctDNA, but it's very, very early. And I would hate for my patients to go on therapy too soon without having a benefit of survival, because these therapies are not only expensive, but they affect the patient's quality of life. And Jack, to what you were saying between a period of it, like early treatment versus prolonged treatment, we are oncologists. Our patients like those, but the less we are in their life, the better they're doing. Like I had called my patients like, "Hi, it's Dr. Duma," and she's like, "Damn, I prefer to get a call from my dermatologist." And I get it. Like we are cancer doctors, right? So the less time they get with us, the better they're doing.
Estela, your thoughts here on current versus future ctDNA use?
I mean, I think that we need a better way to monitor patients with minimal residual disease, and ctDNA seems to have an answer, but it hasn't been tested prospectively. One of the trials we participate in, the Mermaid trial, does have a prospective evaluation of starting treatment based on a ctDNA test. But I will tell you, this test, at least in the United States, there's no control. Like I had a patient who came and told me, "Why didn't you order a Signatera? Why didn't you order a DetermaRx? Like, you're not doing your job." And I'm like, where is the data for all these tests? So I guess, that's another thing, is that you can have all this technology, but until we have the right trial, we could be doing a disservice to patients.